Bonjour mes amis et bienvenue dans un épisode très spécial pour la Oncology pour l'esprit curieux. Je suis Michel Fernando et avec moi mon ami et oncologue extraordinaire, Dr. Joshua Owitz. Now, if you don't speak French, that was perfect vocabulary and pronunciation without any use of Google Translate whatsoever. And Josh is thankfully on mute at the moment, but he is gone bright red with laughter at my flawless French there.
You're not wrong. That was one of your best introductions, Mikey. I'm speechless at the moment, as everyone can hear. And if anyone who is French that is listening, I apologize on Michael's behalf.
I don't know what you're apologizing for. Like that was brilliant. I think native speakers around the world, native French speakers around the world, will be delighted to hear something in their native tongue. But the reason that I'm using my Google Translate version of French is that we have a very special episode following the ESMO Congress, the big European conference in Paris. And we thought we would do a bit of a highlights reel on some of the game-changing studies. We've split this up into 2 episodes because we figured that there's so much to talk about that if we did it all in one episode, we would be talking all day. And we're not going to go into depth with any of our studies that we talk about. It's just going to be very much a highlights reel.
I really think ESMO and ASCO are kind of like a prom, or it's an end of year event for all the really excited kids that they get to come together and talk about all of the work they've done during the year. For those that don't know, Twitter lights up when anything oncologically goes, and there's like standing ovations and lots of food, and just it's years of work culminating in these productions. But it's very cute to see.
It really is like opening night at a big Broadway musical. Like so much work has gone into these studies, and the results are oftentimes spectacular. And like you said, standing ovations, and also it's a great place to network and communicate and see people that, especially now, you haven't seen before. But unfortunately, neither Josh nor I went to ESMO this year. Josh was too busy gallivanting in America, and I was too busy being stuck in Melbourne, where it was raining and cold. But that doesn't stop us talking about the studies that were presented.
Okay, do we want to let's just get started, because we have a lot to talk about. Mikey, do you want to go first?
Yeah, so we've sort of split this up into tumor streams, and I'll be taking our listeners on a very quick dive through some of the highlights in lung cancer. It was quite a heavy ESMO, I think, for lung cancer. But the first study I'll talk about is actually an update, and it's an update on the ADAURA trial, which I think we've talked about the sister trial to ADAURA, which is FLAURA, which is osimertinib in the metastatic setting, but ADAURA was osimertinib in the adjuvant setting. So patients who have had a stage 1B or 1B to 3A non-small cell lung cancer, completely resected, and was found to have an EGFR mutation, specifically exon 19 or L858R, which are the 2 most common types of EGFR mutations. And patients were randomized to either receiving osimertinib, 80 milligrams, or placebo. Now, in standard practice, or in a bygone era, I guess, these sorts of patients would have received adjuvant chemotherapy, but there wasn't a comparator to that. It was quite a large study, 682 patients, and the updated results presented at ESMO this year were a 5-year disease-free survival update after patients completed the treatment duration of 3 years. So you got 3 years of osimertinib or placebo, and then you were just observed. The update was of a median follow-up of 44 months of adjuvant osimertinib, and the fact that we can say 44 months of anything to do with lung cancer is incredible. But tellingly, the median follow-up for the placebo group was 19.6 months. So already we're looking at a significant difference. They basically divided the data into two groups. There was the median disease-free survival, or DFS, for patients with stage 2 or 3A, which are probably the more high-risk patients. They're the ones that would be more likely to get adjuvant treatment. Stage 1s, certainly 1As that were excluded from the trial, sometimes don't, depending, or we're a little bit more hesitant to give adjuvant treatment. But in patients who had stage 2 or 3A disease, the median disease-free survival was 65 months in the osimertinib group versus 21.9 months in the placebo group. Now, Josh, would you like to take a gander at what the hazard ratio of that was?
Wow, that's my hazard ratio.
It is a hazard ratio of wow. Look, it may as well be, because the hazard ratio is actually 0.23. So that is a 77% risk reduction in recurrence, in disease recurrence over the course of 5 years. At 4 years, 70% of patients receiving osimertinib were free of disease. And for those of you who don't know, even cancer, even very small cancers that are resected very early, lung cancers that is, have a very, very high risk of recurrence. And so any treatment that can improve that, certainly to this degree, is astounding.
Yeah, I think. Sorry, I know we do have time limits. I want to add a factoid, Josh's factoid of the day.
Josh's factoid, getting in early there, Josh.
Yeah, I know. Right? So I think from memory, stage 1 to stage 3 risk of recurrence after surgical resection is at least 50%.
I think that's the number that we generally bandy about 50%.
And the other thing is chemotherapy in the adjuvant stage for, I think, stage 3A from memory, and is like 5% benefit.
Yeah, which is not great, but it's pretty much all we have.
Yeah, and stage 2, I think it's almost like a discussion about potentially could benefit, but I don't know how much evidence. Anyway, I know we have such little time today, so I'm going to stop talking, which is a first, and I will let Michael continue.
Yes. So I guess I will only make a couple of more points before moving on. So the DFS, as mentioned before, with the hazard ratio of 0.23, excluded patients with stage 1B disease, so very, very early disease. But if you look at the overall cohort, including those patients, the hazard ratio only goes up slightly to 0.27. Where the DFS was the same in the osimertinib group and 28 months in the placebo group. So even if you include the patients that are sort of by definition going to do better, then the hazard ratio doesn't change very much. The last point that I'll make is that there was a discussion after this presentation, and they looked at the curves, the DFS curves by stage, and it is interesting to note that after 3 years, aka after the patients on the osimertinib arm had completed their treatment, the DFS curve started to fall much more steeply. And so in patients with stage 2, and particularly stage 3A, the DFS curves really started to take a nosedive sort of towards the placebo equivalent. That now they didn't get close, obviously, because otherwise the hazard ratio would be much less dramatic. But it did raise a question as to how long is the duration of osimertinib? I think there was one tweet that said, are we sort of looking at a adjuvant hormone receptor positive breast cancer discussion where higher risk patients get longer durations of osimertinib? But that's obviously an area that needs further study. So that's ADAURA. So very, very exciting. It wouldn't surprise me if osimertinib gets some PBS love in the near future. Based on this, we still don't have overall survival data, but the disease-free survival is almost certainly dramatic enough to be indicative of benefit. So moving right along to the next study for me, which is CODEBREAK 200. Now, some of our more seasoned listeners will be familiar with CODEBREAK 100 of sotorasib, and I've stopped calling it, Josh, sotorasib, because I was listening to the presentation and the person who actually presented CODEBREAK 200 was calling it sotorasib, and I thought, well, if she's calling it sotorasib, then I can't exactly say that I'm pronouncing it the right way.
But Michael, you're always right.
Oh, that's nice. You can stay. You can stay on the podcast. We'll keep you. So CodeBreak 200 is a phase 3 successor to CodeBreak 100, which was a phase 2 trial. So it is patients with KRAS G12C mutant non-small cell lung cancer. Now, we talk quite a bit in practice about EGFR and ALK and ROS1 and MEK and MET, and we're just coming up with more and more mutations and more acronyms in the lung cancer space. But KRAS mutations are actually one of the more common mutations in the lung cancer space. And until sotorasib, we were unable to, we had nothing to treat, so they were considered untreatable. But then CodeBreak 100 came out. Sotorasib we are actually using in the clinical space, and this is the phase 3 sort of confirmatory data. So it was sotorasib versus docetaxel. Docetaxel is the standard of care second-line treatment in lung cancer for patients who have progressed off platinum-based chemotherapy and immunotherapy. Now, patients had to have had at least one previous treatment to get on trial, and it was usually platinum doublet plus IO. But say, for example, they didn't have the IO up front, or they had single agent IO, they could have more than one. So it's sort of one or two plus lines of treatment. Patients with CNS involvement were also included, and that was a stratification. So 340 patients randomized 1-to-1, and interestingly and importantly, crossover was allowed. The primary endpoint was progression-free survival, with secondary endpoints including disease control rate, time to response, and duration of response. Now, CodeBreak 200 met the primary endpoint of PFS with a hazard ratio of 0.66 and a 12-month PFS rate of over double docetaxel. Now, docetaxel in the lung cancer space, unfortunately, is a bit of a joke in that it frequently doesn't work very well. It's quite toxic as well. And this sort of reflects that in that only 10% of patients in the docetaxel group did not progress at the 12-month mark versus almost 25% in the sotorasib group. So significant improvement there. The secondary endpoints that I mentioned before, with the exception of overall survival, were all met. The overall survival was equivalent and not statistically significantly different, with a hazard ratio of 1.01, 10.6 versus 11.3. So close enough for us to probably call it the same. It should be noted, though, that there was a potential influence of crossover, in that 34% of patients in the docetaxel arm had subsequent KRAS inhibitor, and a significant proportion of those were from the crossover. So it's possible that the docetaxel was doing better in this study than it normally would, because I think the original trial had the median overall survival at about 6 to 8 months from memory. So potentially sotorasib is actually better. So CodeBreak 200 shows that sotorasib is probably a nicer and more effective second-line treatment in KRAS G12C mutant non-small cell lung cancer. Next is the IPSOS trial. This is a very interesting trial that I wanted to talk about. And it's because it is addressing a group of patients that are frequently neglected in clinical trials, and that's patients with poor functional status. So the IPSOS trial was a phase 3 study of first-line atezolizumab, a PD-L1 inhibitor, versus single-agent chemotherapy in patients that were deemed not eligible for platinum-containing regimen, which is really the backbone of treatment of lung cancer. Patients were randomized 2-to-1 to receive either atezolizumab or investigated choice of chemotherapy. Now, these chemotherapy choices were interesting because they were vinorelbine or single-agent gemcitabine, which is, I guess, in practice, not what you would reach for if you're trying to give a frail person chemo. At least that's what I've seen in my practice. So treatment was commenced and was continued until progressive disease, or in the atezo arm only, loss of clinical benefit. And that is a potential confounder in that people getting atezo were allowed to continue for longer than patients in the control arm. But the selection criteria were quite broad in that patients were enrolled regardless of PD-L1 expression. Their selection criteria is the inverse of most trials, in that it was they had to have an ECOG of 2 or 3, so frail, and patients with ECOG 0 to 1 were allowed if they were greater than or equal to 70 years old with substantial comorbidities or other contraindications to platinum chemotherapy. So these are frail patients.
Is this really a fair trial? If you're frail and you've got immunotherapy, which is generally better tolerated than chemo, even if it's vinorelbine or whatever else they want to sugarcoat it with, like the immunotherapy is going to do better.
Well, yes, you're exactly right, and the immunotherapy did do better, quite significantly, in fact. But I guess there's never really been objective data to confirm that. Like, it's the value of this trial, I think, is sort of confirming what we're sort of already doing, because when we do have these proof of concept.
It's proof of concept. Oh, I wanted to say the phrase. It's, everybody, it is proof of concept as by Josh. Yeah, Michael, keep going.
as per Josh, it's proof of concept. No one else has ever used that phrase in the history of human race.
Exactly.
So this really is a proof of concept, as per Josh, of what we normally do with these patients, which is when we do have frail patients, we give them immunotherapy because it is usually better tolerated with fewer immediate side effects. There has been, I think, some debate about whether patient or how likely patients with poor performance status are to respond to immunotherapy, because there was evidence that patients with poorer performance status sometimes actually did worse. But importantly, with this study, so the overall survival was numerically better, not hugely. I mean, it was statistically significant, 10 versus 9 months, with a hazard ratio of 0.78, p-value of 0.02, so it meets the statistical criteria. 44% of the patients in the atezo group were alive at 1 year and 24% were alive at 2 years. And there were no new toxicity signals compared to the pivotal studies. So it's probably, again, confirming what we already knew or what we were already doing, which is giving patients a quote unquote gentler treatment, but it's confirming that it is efficacious. And finally, I thought I would finish with 3 very quick hits before handing le baton over to Josh. And so, first up is Checkmate 816, which is an already published study. It's another update of neoadjuvant treatment in potentially resectable non-small cell lung cancer. Now, neoadjuvant treatment is not something that's commonly done, at least in Australia, but it really is gaining traction and gaining momentum as a important weapon in our arsenal. So Checkmate 816 was chemotherapy plus minus nivolumab every 3 weeks for 3 cycles followed by resection. There was a IPI and Nivo arm, but that wasn't talked about in the post-hoc analysis. I'm sure in a later episode, Josh will dive deeper into Checkmate 816. But they were looking much like the neoadjuvant breast space at pathological complete response and event-free survival, both of which were met in the original analysis. But they were sort of teasing out a few bits and pieces, specifically looking at whether things like tumor regression, the percentage of residual viable tumor in the resection specimen, lymph node involvement, was a potential marker for event-free survival, basically trying to validate, my take that there was trying to validate the pathological complete response in lung cancer, as it has been in breast cancer. And they showed that there was benefit regardless of lymph node involvement, but if patients had greater tumor regression and less percentage of residual viable tumor, it did predict event-free survival at 2 years. So, I mean, it stands to reason, but it's important to confirm, again, proof of concept, that if you respond better to the initial treatment, then you're more likely to have a sustained response.
I'm very excited for this trial, and as they expand it, this is a game changer. I know it's not the first one we spoke about, but this is a game changer for lung. And once we kind of tick off that and get some bigger studies out, that's going to be, I think it's going to be the standard of care. I'm obviously not the specialist or the surgeon, but my opinion, Josh's fun opinions, is that this is going to be the standard of care. So I think watch this space. It's going to be really interesting how things progress.
Yeah, and it sort of reflects a move towards neoadjuvant treatment of early cancers across oncology. Like we're seeing, obviously, in breast, in pancreas, there's rumblings of it, I think, in renal cell. There's also rumblings, as we'll see in the next episode on ESMO, in colorectal. And so this push towards putting systemic therapy up front and then snipping out what's left and seeing how much of a response you've had, both what do they call it, Josh? A in vivo response test. So you're stress testing the cancer and seeing how well it responds to treatment. That's going to be something that we see across oncology as a whole. Moving on, just mindful of getting bogged down as we so often do on this podcast. In a similar vein to Checkmate 816, there was the Increase trial. Now, if the Checkmate 816 was sort of pop rock, Increase is heavy metal, because what they do is they basically take literally every non-surgical treatment we have of early lung cancer and throw it at the patient up front. So you've got chemotherapy, 2 rounds of platinum doublet chemotherapy every 3 weeks. You've got Ipi-Nivo on day 1 and Nivo on day 22. And as the cherry on top, you have 50 to 60 grays of radiotherapy. So this really, really is heavy duty treatment. And so obviously patients had to be fit. It is a single arm prospective small phase 2 trial with only 26 patients, 24 of which proceeded to surgery. But it did show that the pathological complete response rate was 63% of those who received surgery. Now, the patients who seem to respond best in this very small cohort seem to be mostly current smokers who had squamous cell carcinoma. We know that squamous cell in at least the gastric and gastroesophageal space, the esophageal space, does tend to respond better to immunotherapy than adenocarcinoma. And current smokers, there's theories about sort of heightened immunogenicity of cancers. But of course, with such a heavy treatment, the adverse events were significant, even in this tiny cohort. 100% of patients had treatment-related adverse events of any grade. 81% had adverse events of grade 3 to 4, and one patient had a grade 5 adverse event. So for those of you who don't know, a grade 5 adverse event is a fatal adverse event. So it's effective, but is it going to see widespread adoption? I have my doubts, if I'm honest. It might be too much, but at the same time, it might go the way of FOLFIRINOX in colorectal cancer, where you really, if you pick your patients carefully, you can get some spectacular results.
That was going to be my point. If they're young and they're robust and it's got some good evidence, if you hit them hard, you might see something spectacular.
Yeah, and I think it's also worth noting, I couldn't find the breakdown for this, but some of these patients had quite significant disease. So some of them, so the selection criteria, the tumor had to be T3 to 4, so you're already looking at a big tumor. But significantly, some people were N2. And in my experience, having difficult to reach, usually hilar lymph nodes can be one of the main things that makes the surgeon say, I don't think I can cut that out. We'll need to do chemo rats. So if we're converting these patients to resectable, then that is huge, because we might be able to salvage, I guess, a greater proportion of patients with stage 3 lung cancer. But again, at a significant cost. And the last study I'll talk about, I'll be honest, I chose mainly for its name because it's called the Apple trial. But it is actually a very interesting trial. So some of our listeners will be familiar with Dynamic, which is a colorectal trial that was published at ASCO that focused on circulating tumor DNA in the colorectal space and how this can be used as a marker for escalation of treatment in the adjuvant or neoadjuvant setting. So Apple is a similar sort of trial, multi-arm phase 2 study of EGFR mutant treatment-naive non-small cell lung cancer. And it's aiming to evaluate the feasibility of longitudinal plasma, so circulating EGFR T790M monitoring. Now, this is getting a little bit complex, but in summary, in order to access osimertinib after you had been on an older generation drug such as gefitinib or erlotinib, you had to have this T790M, which is a resistance mutation, in order to get it. So this is testing basically whether we can detect this T790M mutation in the bloodstream, because previously to detect it, you had to take another biopsy, which of course was very difficult for the patient. So the results presented at ESMO were for two of the arms. Arm B, which was gefitinib until the emergence of ctDNA T790M, or progression via the usual process, which is RECIST, which is where they meet imaging criteria for progression. And then results from arm C, which was gefitinib until PD by RECIST, and then they were put on osimertinib. So the primary endpoint was the PFS on osimertinib at 18 months, which they gave the very trendy acronym PFSR OSI 18, which I don't know if that's any quicker to say. So in terms of the arm B, which was the ctDNA study, which I guess is the one we're most interested in, 17% of patients switched to osimertinib from gefitinib based on ctDNA before RECIST. The PFS on osimertinib at 18 months, so patients who had not progressed on osimertinib after the switch at the 18-month mark, was almost 70%. The median progression-free survival was 22 months. And the overall survival wasn't reached, as one would expect for osimertinib. Now, in terms of where this actually fits into our practice, I don't know that it'll find a place, because T790M is becoming one of the, I guess, the least requested tests in the oncology space, because everybody has access to osimertinib. But I guess if T790M also can confer resistance to osimertinib, then the next generation of EGFR inhibitors, where we'll need to prove the presence of this resistance mutation, we might be able to prove that based on a blood test as opposed to a biopsy. And this whole concept of liquid biopsies and circulating tumor DNA and how it's going to impact our more our diagnostic process than our treatment process, but it is a massive area of growth and a fascinating one. So that's really what I wanted to say about Apple, in addition to the name.
Well done.
Thank you. I got through all of that in about half an hour, which on this podcast is rapid fire. So Josh has a couple of other tumor streams he wants to talk about, so I will hand things over to him. Take it away,
Mike.
Josh.
I'm ready. I'm ready for this. So I'm going to I actually made a ton of notes, but I'm going to summarize things very briefly, because I'm aware that it's a bit intense listening to multiple trials. So the first trial I'll be talking about is the BELLINI trial. Now, this is IPI plus Nivo, so ipilimumab plus nivolumab in early stage triple negative breast cancer with tumor infiltrating lymphocytes, which I'm going to describe as TILs. Now, background to this, we're using single agent immunotherapy in triple negative breast cancers, right? So the question they wanted to know is, what happens if you add a anti-CTLA-4? Do you get better outcomes? What happens to the ctDNA? What happens to the TILs, right? So that's kind of the concept, and that's how they kind of broke this trial up. Now, I'm not going to go into that much detail because a lot of it's basic sciences, but the things you need to know. So partial responses was seen in 3 out of 16 patients for nivolumab and 4 out of 15 for nivolumab plus ipilimumab. Interestingly, of those 7, at least 3 were considered TIL high, so that's high lymphocyte counts, and another 4 were intermediate TILs, right? So we know out of the 7, they've got at least intermediate TILs. There were no response in patients that had low TILs, so that's something to think about in future referencing for proof of concept. What are we going to do for other tumor streams, right? And another interesting fact, and I'm trying very hard to summarize this and do it fast, is that the ctDNA clearance was seen higher. There were more patients that had ctDNA clearance at 4 weeks in the ipi-nivo versus that of the nivolumab. And I'm not going to talk about safety effect profiles. You can see that in lots of other different studies. So what we do note is that there was a partial radiological response. There's also increased TILs in Ipi-Nivo, right? And so the question with this is whether or not we can use these as surrogate markers. Are they going to have a role in the future? It's a very brief overview, I admit, but it's just something to kind of think about. Mikey, did you have any questions?
I think that TILs is another area, much like sort of ctDNA and liquid biopsies, that we're going to be doing a lot of. I think it's going to sort of end up being like PD-L1 expression for certain tumors. Like we'll say, oh, the TILs are high, the TILs are this, the TILs are that, and we'll be able to tailor treatment to patients that are TILs high. Because you said that there was no response in patients who were low or absent tumor infiltrating lymphocytes. Is that right?
Yeah, correct. And also, they also looked at CD8, which I haven't mentioned really, but from memory, CD8 was interesting, was not significantly high in responders. But either way, all responders had TILs of at least or equal to 40%. And so I think Michael's right. This is going to be a surrogate marker, much like what we do with other tumor streams at present.
Because there's no point giving Ipi-Nivo, which, as anyone who's given it knows, can be very, very problematic if the data is that patients aren't going to respond.
100%. All right. I'm going to keep moving in the interest of time. The next trial I'll talk about is the TROPICS-02 update. So this is the overall survival. It's a phase 3 trial. It's using SG, the new kid on the block, the big kid. So that's sacituzumab govitecan versus treatment physician choice in patients with hormone receptor positive, HER2 negative metastatic breast cancer. And so the synopsis of this, from what I was reading, is that, look, I'm going to say this is, they were a bit worried that this wasn't actually going to have an overall survival benefit when the initial data came out. So there was a progression-free survival benefit of, from memory, I think it was 5.5 versus 4 months with a hazard ratio of 0.66. And so the question is, if it's positive, where does it sit in our list of treatment options after the gold standard, which is a CDK4/6 inhibitor and endocrine therapy? So they are broken up, as I said before, and I'm not going to go through the toxicities. That's all going to be on the websites. But what they did find, which is actually was a positive study. So the median overall survival was 14.4 months in SG. So I have abbreviated the intervention drug versus the treatment physician choice was 11.2 months. And that brings a stratified hazard ratio of 0.79. Okay, so the 12-month overall survival percentage was 61 versus 47%. Yes, I know these aren't massively high, but remember, this is someone that's progressed through initial lines of therapy, the gold standard, which is the CDK4/6. Some people have had, so what I said here, at least one line of endocrine therapy, taxane, CDK4/6, and at least 2, but no more than 4 lines of chemotherapy. So usually pretty heavily pre-treated. It'd be interesting to see how many lines of therapy they had. And I don't have that in my notes, but I think that's something that would be really interesting. The duration of response was 8.1 versus 5.6 months as well. And so that's something that's important to note. And the ORR was 57 versus 38%. Now, yes, this is a positive study, but where does it fit in our paradigm of treatment? And that's something that I think we still probably need more investigations to really talk about, because hormone receptor positive breast cancer has multiple lines of therapy already in the metastatic space, and you have to kind of figure out where it would fit that would be most beneficial. But it is an interesting point, and it's another quiver in our bow, or whatever the phrase goes, that we actually
arrow in our quiver, Josh. Arrow in our quiver.
That's why I keep you around. Arrow in our quiver. And so it's going to be an interesting discussion moving forward. And it will probably be approved, but that's just something to talk about. I might continue on in the interest of time.
Please do. We're doing very well. We're only slightly hammering.
We're slightly hammering and slightly hemorrhaging. No. So the next trial I'll be talking about is where we're switching tact a little bit just for everyone, just to keep you on your toes. We're going to be talking about hepatocellular carcinoma with the LEAP-002 study, which was a trial of those that have HCC positive, no prior treatment. They weren't amenable to curative surgery therapy, which is surgery, right? They have a good performance status, and they were essentially stratified to lenvatinib, which is a treatment option, or lenvatinib plus pembrolizumab, which is kind of the intervention arm. It's like, is it going to be better than just standard lenvatinib? Who can say? I know, Mikey knows, but maybe you in the audience don't. But I'm just building it up. Anyway,
You're building it up so much, Josh. It better be a positive study.
now you're being mean, Mikey. So, 794 patients were enrolled. Median follow-up was 32 months. 534 overall survival events occurred, and at the end of the trial, it's sad, but 9% of patients remained on lenvatinib, and 6.1% on lenvatinib. 9% of patients on lenvatinib plus pembro, and 6% on lenvatinib alone. So the median overall survival was 21.2 months versus 19 months, comparing lenvatinib plus pembro versus single agent lenvatinib. So unfortunately, and Mikey, you stole my thunder, this was not a positive trial. It was not statistically significant, meaning that there was no difference really between the extra immunotherapy versus the single agent alone, which is a little bit sad. I think it would have been nice to see another treatment option for hepatocellular carcinoma. And there are some further studies going on, including the phase 3 LEAP-12 study, which is the lenvatinib, pembrolizumab, and the TACE, which is currently under investigation. But at the moment, there's no real, I guess that there's no benefit. If you look at the hazard ratio, it was 0.84, but the P was 0.02, and it didn't meet the pre-specified targets.
It's a good concept. Like, it's following the RCC concept of combining a TKI with immunotherapy, and it's worked fairly successfully in RCC. So it's a bit of a surprise that HCC it didn't really work, but I guess that just means that as those of you who listened to our hepatobiliary episode, that atezo-bev still remains the top dog in the HCC space.
And if you haven't listened to that, go back, listen to it.
Go listen to it. It's good.
It's
Spock shows up.
Let's keep moving. So the fourth one I would like to talk about, and I'm going to say I summarize better than Michael. Just going to put it out there, but feel free to send us a comment if you agree. This is a combination trial. It's the Prodigy 65 UCGI 36 GemPax.
So catchy.
I know, thank you. Whoever thought of it was just really wanting to sell it. Either way, what my understanding of this trial is that this is a pancreatic cancer trial, right? So someone's got metastatic pancreatic ductal adenocarcinoma. They've progressed through FOLFIRINOX, which is the gold standard, the standard of care. Yeah, it's tough, but it's the best chemo drug we have. Remember, treatment for pancreatic cancer sucks. There are very few options. And this is a question that there are no prospective trials evaluating second-line chemotherapy after this failure. The thing with the modern-day oncology era is that no one wants to study chemotherapy. There's no money in it. There is still a role for chemotherapy. That's what I think we fail to say a lot. So this is a good trial. Also, it doesn't use nab-paclitaxel, which is still currently under patent. It just uses paclitaxel. So they stratified people in a 2-to-1. So arm 1 was the experimental arm, which was gemcitabine and paclitaxel, and arm B was the control arm, which was gemcitabine. They wanted to look at overall survival and I believe progression-free survival. So arm A, which remember from several seconds ago, is the intervention arm. That was 6.4 months versus 5.5 months in the control arm. Hazard ratio was 0.87 with a p-value of 0.4. So actually not a huge difference, really. It's not a statistically significant overall survival, which I thought was something interesting to say. But if we look at the progression-free survival, from memory, when I read through this, I'm pretty sure this one was statistically significant, but it was 3.1 months versus 2 months. So while it didn't show any overall survival, it was statistically improved both progression-free survival and objective response rates, which is what you want in this cohort. Remember, people with pancreatic cancer that's metastatic, if they live up to 2 years, you're doing really well. They're probably going to live 12 months.
That's an absolute miracle, 2 years for metastatic pancreatic cancer.
Well, I'm thinking it's they have their Whipples, they get the surgery removed, the cancer removed, they then progress 10 months later, which is usually what happens, or less, and then they go on to the metastatic treatment. So that was kind of my thought. Terrible, but this is something that at least we have some more data to kind of equip our knowledge base of when we kind of explain to patients what are we doing. And so my final article, Article 5. I'm going fast. So
Article 5 of the Constitution.
Of the Constitution, which neither of us know the Australian Constitution.
The Constitution of Josh.
Josh is, I am sleepy. No, the Constitution. The Constitution. So this is, oh boy. So we're looking at 2 early studies investigating anti-cancer activity of derazantinib and the Relay 4008 in patients with FGFR inhibitor naive cholangiocarcinoma patients. Mikey, have you come across any trials looking at the FGFR inhibitors or like the fusion proteins?
I have. I think there are a couple that were recently closed. They were mostly in the ones that I was familiar with were in the bladder cancer, but I am very vaguely aware of the cholangio studies. But please illuminate, Josh. You are so good at illuminating dark spaces.
Something like that. So, guys, I'm not going to talk much about the fusion protein, but essentially this fusion of overexpression has been associated with cancers. Now, it's been validated as FGFR2 as a target in cholangiocarcinoma, with achieving an objective response rate. This is previous studies, everyone, of about 20 to 40%, and duration of response of 5 to 9 months, which in cholangio is absolutely fantastic. However, off-target toxicities and emergence of polyclonal FGFR2 resistance limits their efficacy. So that's kind of one of the limitations, like most of our targeted therapies. So the Relay 4008 trial was the first in a highly selective, potent FGFR2 inhibitor designed to target the driver alteration and the resistance mutation. Bam, bam. Let's stop it from becoming resistant and just keep it working. I love this already.
It's very much like the old BRAF and MEK. We know that BRAF by itself doesn't do too much, but you add a MEK inhibitor and it really cuts the resistance down.
Yeah, 100%, Mikey. You hit the nail on the head. So this Relay 4008 study enrolled patients with the advanced tumours, and they were given this tablet, which essentially they're the outcomes. They wanted objective response rates. They wanted duration of response. They wanted safety. I'm doing the physician pause, Michael, to say everyone's like, I'm so excited.
The gravitas pause.
The gravitas pause. Okay, so if we're looking at the FGFR2, the objective response rates was, I think, 15, so 88.2%, I think, had an objective response rate out of the patient. So that's amazing. And confirmed was 82.4. So partial response in the intervention drug, so 82.4%. Stable disease was 11.8%. Response ongoing was 100% of the patients that responded. So amazing. Disease control rate, their number was 17, and so that's 100% of patients, and those that remained on treatment was 15, which is 88.2% of patients. This is with a specific dose, mind you, and they've got another dosing section which shows, yes, a lower, I guess, outcome, but I guess part of these early phase trials is we're looking to see what the best dose is, what the efficacy is, what the outcomes in. But guys, this is the trial I'm excited about. apart from the one Michael said, which I was also excited about. But I am more excited about this because this FGFR mutation, once we get a good drug and a good dosing level, this is what we're going to be treating that subset of cholangiocarcinomas with.
That's a bold, bold statement, Josh.
I'm all about the bold statements here, but you know what? I think there are some trains of thought which, immunotherapy is the future. All we do is immunotherapy. It's going to be like the new chemo. I think we need to keep looking at the molecular side of this because there's only so much that kind of hitting a cancer with the hammer is going to work. We need bigger trials, of course, guys. I don't want to say that we can
go out and buy shares in the FGFR2 market. That's what Josh is saying. He's giving financial advice now.
It. Do your own research, right? I actually have zero idea which company makes this, and that's bad. But cholangio, for those that do treat it, a lot of the time they rock up for treatment and they're jaundice and they've got obstructive jaundice, and that's in a couple of weeks, and they end up in hospital and everything gets delayed, and it's all really sad and really sudden and really acute. So I'm excited for this trial. What do you think, Michael? Are you excited?
I am excited about anything that gives us a new target that has potential efficacy in pancreatic biliary cancer, because it is one of the most depressingly sparse places to work and treat in the oncology space. As we have said before, and doubtless we'll say again, minds much smarter than ours have tried to find the silver bullet in treating these cancers, and it just has eluded so many people for so long. So if FGFR2 delivers on the promise that it has shown in these early studies, then it will be absolutely inspiring. And you can guarantee, you can bet bottom dollar that if the phase 3 version of these trials is successful, that's getting a standing ovation.
That's probably getting a Nobel Prize.
Well, yeah. Standing ovation at ESMO, Nobel Prize, they're pretty much one and the same, aren't they?
And then Hollywood.
Yes, and a daytime TV made about the making of. There was one of Herceptin, a daytime TV movie with Harry Connick Jr.
I personally have not seen it. What was it? Was it good? Was it worth watching?
I haven't watched it. I read the Wikipedia article. But anyway, it's this is, I think, the point in every single show that it completely goes off the rails. So, Josh, do you have any other trials to talk about?
No, I think I gave the 5 ones I'm excited about. But in summary, we have managed to go through 10 trials today in sub an hour. So I think that Michael and I both deserve a small round of applause.
A Nobel Prize. We both deserve a Nobel Prize in speed.
I think the exciting thing there, we gave a range of discussion points about immunotherapy, chemotherapy, targeted therapy. Things are moving forward, and there's a lot of exciting work being done. We will leave links to the description for all of these abstracts that you can find them. And feel free to tune in next week for ESMO Part 2, where we will probably go over an hour.
And I will also say, Josh, in case our listeners weren't aware, that we also have a Twitter on an internet. So find us at Inquisitive Onc on Twitter. Follow us and shoot us a message. As you can probably tell, we're both fairly happy-go-lucky guys, happy to chat, and would love to hear from you. And if you have any special requests about episodes for us to do in the future, drop us a line.
We do not have a TikTok.
No one wants to see our TikTok. It's confined to the dark web, and it's never seeing the light of day.
No, but we hope you enjoyed the summary, and it gives a bit of an idea of some future trials. Also, heads up, if you are doing onc training, make sure you keep an eye, because I've had a couple of FGFR2 trials going on, and they're pretty exciting stuff. And I think, think of your patients early, especially in the cholangio space, because they need to be referred straight away for this mutation testing.
And I think it goes without saying, if you have a chance to go to ESMO or ASCO, take it and run with it. I don't think neither of us have been to either one of these major conferences overseas for obvious reasons. But I don't know about you, Josh. I'm hoping to go to Madrid next year.
Very keen to hang out in Madrid with you, Michael. I think it'll be fun.
Sounds
Maybe
good.
I'll rock up in your suitcase.
Well, not now. You've completely spoiled that plot for us. Anyway, we're going to wrap this up because this is losing traction very quickly. Thanks everybody for listening, and we will see you next time for part 2. Bye bye.
See you then. Bye.